Oh, good evening, colleagues. Yeah, I'm excited to be talking to you tonight on quite a broad topic. I try to give a practical approach because I think that is what is important for us in clinical practice, to see how we can help ourselves manage these patients better, and also to improve and reduce the maternal mortality rate and the morbidity related to hypertensive disorders in pregnancy. This slide is just a disclaimer that I have nothing to declare regarding the presentation. We have started. So what you're going to look or discuss tonight will be on definition of hypertensive disorders of pregnancy. Then we look at the scope of the problem, classification, screening and prevention, prognosis, and then we conclude. Are you seeing my slides?
Yes, we are seeing them for now. Yes, all is good. Thanks.
Okay, good. Let's move on then. All right, good. So the first slide that I put forward is on the maternal cardiovascular function in pregnancy. And this slide just want to highlight the physiological changes that happens during pregnancy before we go on to speak about the hypertensive disorders of pregnancy, which is the pathological or the opposite of what normally happens during pregnancy. We know very much that pregnancy is a unique condition that grossly changes the woman's physiological changes, specifically the cardiovascular system. And we know that if there's any malfunction or maladaptation to these cardiovascular changes of pregnancy, this is then what is related or associated with hypertensive disorders of pregnancy. And you can all see that in the first trimester, as you can see, there is a decrease in the vascular resistance, subsequently an increase in cardiac output and heart rate, and significantly a drop of blood pressure, about 10%, although it is not significant. You can move on to the second trimester and third trimester. There is significant drop in the systemic vascular resistance, and subsequently that reduces the blood pressure by up to 20% from the baseline blood pressure. So it is very important when we are reviewing the patients also to go back and review what was the initial blood pressure, because we know that as the pregnancy progresses on, we expect the blood pressure literally to drop by up to about 20% from the baseline blood pressure. And contrary to that, if the opposite happens in hypertensive disorders in pregnancy, whereby the blood pressure increases. And then you can see as well, this goes on into the third trimester and subsequently in the postpartum period, the blood, all the cardiovascular functions returns to the baseline. And it's very important to understand the basic physiology so that we can understand the pathology that happens with the hypertensive disorders of pregnancy. And it's very important, I think, for colleagues to just recap and really understand these physiological changes. So when we speak about hypertensive disorders in pregnancy, by definition, it's any hypertension during pregnancy up to 12 weeks after delivery. And we have already highlighted in the previous slide that this is related to the failure to achieve the normal cardiovascular adaptation. As you know, that the opposite happens. We want the blood pressure to drop during normal pregnancy, but the opposite happens in those patients that have hypertensive disorders in pregnancy. So to look at the problem, we know very much globally, hypertension is the most commonly medical condition encountered during pregnancy, and it is on the rise globally across everywhere. Everyone is talking about hypertensive disorders, and this is mainly attributed to many factors. And one of the factors, we know that the women tend to delay their age of their first pregnancy, usually in the after late advanced maternal ages, and we know that with advanced age there is normal changes in the cardiovascular changes, as we'll see later in the presentation, that we can highlight some of these issues. And it is reported to complicate about 10% of all pregnancies, although in my view I think this percentage is probably more than what is reported in literature, especially on this part of the world in Africa, specifically with us in sub-Saharan Africa. And why I mentioned it is important to know that even with the European data or the American data, we know very much that there is racial discrepancies in terms of the race that is affected by hypertensive disorders, and we know the blacks are typically more commonly affected by this condition. And perhaps I still think that this number is perhaps more than what is really reported in literature. What on the sad note is that about 60% of the deaths that are associated with hypertensive disorders are often associated with substandard care. So meaning that changes to caring of this patient could have perhaps made a difference in the outcome of these patients. And that is why we have this webinar tonight to try and reduce this percentage that is associated with substandard care. Hopefully we can share the knowledge, we'll be able to improve in how we are looking after our patients. And as you can see, the deaths from preeclampsia are potentially preventable, as we can also see later in the presentation when we speak about prevention, especially of preeclampsia, which is the most malignant form of the hypertensive disorders of pregnancy. And it is also important to note that those women with hypertensive disorders of pregnancy have about a 2.1 and a 3.5 and a 3.5 increased folds in terms of having poor outcomes such as small for gestational age, preterm deaths, low birth weight, and this is when they are compared to the normotensive pregnancy. Although we focus mainly on the maternal, we also need to note that there is also poor perinatal outcomes that are associated with this condition, and we need to be aware of this. This data is extrapolated from the last Savings Mothers report that talks about the causes of maternal death in South Africa. And we can all appreciate that hypertensive disorders is the highest leading cause of direct maternal deaths related to obstetrics. And it's the second only to the non-pregnancy related infections. But when we speak about direct obstetric maternal deaths, hypertensive is a leading cause. And clearly, it just shows you the problem that we are sitting with. And equally so, this data is also from the 2011 to 20 assessment of these causes of perinatal maternal deaths and the morbidity between 2011 and 2016. And interestingly, as you can see there, HT stands for hypertension, OH is obstetric hemorrhage, and the rest is ectopic miscarriages and all the other causes that are related to maternal mortality and morbidity. What has come out to be interesting is that over the years from 2011 to 2016, hypertension disorders in pregnancy is on a rise, has increased by up to 14%, whereas all the other causes of maternal morbidity and mortality have decreased, and significantly the most improvement has been made in those of patients with non-pregnancy related infections, especially with HIV, which has dropped significantly by nearly half. So clearly, again, this slide just highlights the issues that are related to hypertensive disorders of pregnancy and the problems that we are perhaps facing globally. And the picture is pretty much similar here. This data that I'm projecting is from the confidential inquiries into the maternal deaths in Namibia between 2018 and 2021. And we can all appreciate that hypertensive disorders is still one of the leading causes, although in Namibia we're still struggling with obstetric hemorrhage. Hypertensive disorders came to be the second leading cause of maternal deaths. And again, as I earlier highlighted one of the key messages from this report, it also highlighted that up to about 57% of all these cases of maternal deaths could have been prevented had we have been especially with, you can appreciate the lack of expertise among the healthcare workers. And this again highlights the importance of these webinars. When it comes to those hypertensive disorders in pregnancy, then we sub-analyze further these causes, and one of the leading causes of why women died from this condition of hypertensive disorders, it was mainly because of a stroke in those patients that had eclampsia. Contrary to that, the data that I presented from Namibia and South Africa In the UK, this data projects the Embrace report between 2018 and 2020. And I would want to bring to your attention the incidences of preeclampsia in that part of the world. And you can appreciate that they are not worried about that. They are more worried about psychiatric conditions, such as especially suicides appears to be one of the why women die during pregnancy, cardiac diseases. And it just shows you that with a better training and a better healthcare system, we will be able to reduce the deaths related to preeclampsia and the hypertensive disorders in pregnancy. And I'll keep on mentioning preeclampsia because we know that it is the leading cause of among the hypertensive disorders of pregnancy, as we see later when we classify them. Again, this data is also from the Embrace report, and it just again highlights that hypertensive disorder is literally one of the worries that's part of the world. And you see most of their cases, they die from non-obstetric related complications, especially psychiatric conditions and the cardiac conditions. I just want to highlight something on the blood pressure measurement during pregnancy. We know that globally, we moved away from the old tradition of using the sphygmomanometer that uses the mercury, and we mainly now uses the oscillator automated devices. But it is very important to know that to assess whether the devices that you are using are validated for use during pregnancy, and especially to diagnose preeclampsia, because there are some devices that are not validated, and they may give us either false positive or false negative blood pressures. It is also important to note of the women, which must be in a sitting position with flat feet on the floor, not crossed. And it is also important to use the right cuff. And we know that preferably we must use the large cuff, especially for those patients that have a mid-upper arm circumference more than 33 centimeters. And it is also important to note that in 2017, the American College of Cardiology and American Heart Association reclassified the threshold for diagnosing hypertension in a non-pregnant patient, be it men or women, and that has been reclassified to a lower threshold of 130 over 180, and it's referred to as a stage 1 hypertension. However, that diagnostic threshold has not yet been adopted in pregnant patients, although there is a data to prove that, especially this study by Bello et al. In 2021, looked at whether these changes, 2017 changes in the American College of Cardiology and American Heart Association can be adopted or implemented among the pregnant women. And they actually found that significant result to note that by using a lower diagnostic threshold of about 130 to 180, appears to identify women that are at risk of adverse events, and these adverse events are both maternal and fetal. So perhaps don't be surprised in the future if we also have this changed, whereby we will have this lower diagnostic threshold. We know very much that in the latest South African guidelines for the management of hypertensive disorders in pregnancy, the group 100 with BPs of 130 over 80 to 140 over 90 are referred to as prehypertension. And this group is the one that should trigger or raise a flag, and they should be followed up closely as they are known to be at risk of going on to develop hypertensive disorders in pregnancy. And as you can see by this study by Bello et al., it appears that there is evidence to show that. And then importantly, what is also important to note is to note that most cardiovascular events of bad outcomes can happen with the blood pressure of a systolic of between 140 to 160, and also in those ones with a diastolic between 90 and 109. And what I want to highlight is that we tend to believe that most cardiovascular events will be happening in those patients that are having acute severe hypertension or a BP more than 160 over 110. But it appears that as evidence heavy that is not necessarily the truth. And anyone in that BP range is actually the BP range that we see most cardiovascular events. And we just need to be aware that any blood pressure in pregnancy must be treated with the respect it deserves, and anything can happen. So when it comes to the diagnosis of hypertension in pregnancy, we mentioned about the issue of the 2017 changes in the American Heart Association. That has not yet been implemented in pregnancy. We still use the old tradition of diagnosing hypertension, which is a systolic blood pressure of more than 100 and greater than or equal to 140 millimeters of mercury, or a diastolic of more than greater than or equal to 90 on more than 2 occasions, at least 4 hours apart, or any patients that have severe acute hypertension or a BP of more than or greater than or equal to 160 over 110. And this can be repeated in 15 minutes to confirm the diagnosis. And it is also important to note that any patient that is also having this acute severe hypertension is also identified as a surrogate marker for adverse maternal events and perinatal outcomes. Again, we also need to note of the baseline blood pressure changes. Remember, one of this, when I mentioned earlier about the physiological changes in pregnancy, blood pressure is supposed to drop up by about 20%. If you have an increase in blood pressure that is reported to be, although it's really not considered part of the diagnostic criteria, any raise in the blood pressure that is more than 32 over 15, it can be considered to be as a red flag, and you need to follow up these patients closely, because we do not expect their blood pressure to increase. So again, it goes back to the importance of the initial baseline blood pressure as a reference point. In terms of classification, globally, we use the international study for the Society for the Study of the Hypertensive Disorders in Pregnancy. And the classification that we use can be divided into 5 groups. We have the pre-existing patients that have hypertension, or those ones that are known as chronic hypertension, which can either be an essential chronic hypertension or secondary chronic hypertension. Or this can also be a blood pressure that is diagnosed for the first time during pregnancy in a patient, a woman with a pregnancy that is less than 20 weeks. And it is important to note that 1 in 5 of these patients that are having chronic hypertension are at risk of developing superimposed preeclampsia. And we know that preeclampsia is associated with a poor maternal and fetal outcome. The other group is the hypertension that is diagnosed purely after 20 weeks. And this can either be classified as a gestational hypertension, and we know that with gestational hypertension, there is about 25% risk of preeclampsia, and then preeclampsia, and also those patients with chronic hypertension that goes on to develop preeclampsia, and this is known as chronic hypertension with superimposed preeclampsia. There is also this group of patients with what is known as white coat hypertension, and we know that white coat hypertension is elevated blood pressure in the clinical setting, but in a home setting, the blood pressure is normalized. And this patient, if you suspect that it's a white coat hypertension, you can actually, it is advisable that this patient can have a home or what is known as an ambulatory blood pressure monitoring for some time, and they come back, and then you assess if the blood pressure is elevated in a home setting for you to make a diagnosis. So we are now going to look into these different classifications, starting with the chronic hypertension. As we know that this is can either be pre-existing or diagnosed for the first time during pregnancy. And the key here is that once a patient is having pre-existing chronic hypertension, the approach when you see the patient for the first time is that you need to review the medication if they are already on treatment. And the aim is we know that some of the antihypertensives, such as the ACE inhibitors and the angiotensin receptor blockers, are known to be teratogenic during pregnancy, and we want to remove those medications and start them on medications that are considered to be safe during pregnancy. Or if they are diagnosed for the first time during pregnancy, you start them on antihypertensive. And any of these medications that are projected here, such as alpha-methyl dopa calcium channel blockers, such as nifedipine XL and amlodipine, they hold equal strength in terms of using them as a first line. And we know that the mostly commonly used drug during pregnancy, especially this part of the world, is alpha-methyl dopa, but nifedipine and amlodipine are equally effective, and they are also found to be safe. So you can use whatever you have in your setting, and they hold equal strength in terms of the first line in managing these patients. These patients should be started on aspirin as part of their management, because we already mentioned that 1 in 5 of these patients with chronic hypertension are at risk of developing preeclampsia. And as we'll see later, aspirin is found to prevent preeclampsia. And this should preferably be started before 16 weeks. And we will highlight why it is important to start it before 16 weeks, because anytime after 16 weeks, it is too late for aspirin to have an effect on the outcome. It is also important that these patients must all have a baseline bloods, as they will see later that this blood pressure, laboratory monitoring is very important in managing patients with hypertensive disorders and of pregnancy. And the baseline bloods that are important is the hemoglobin, platelets, the liver function tests such as AST and the ALT, urea and creatinine test. And the SONA should be done to evaluate the fetus. And they should have a baseline urine PCR, or if you have a 24-hour urine GUP, that can also be done. And preferably, it is also advisable that they should have a renal ultrasound to assess for the end organ target disease of hypertensive disorder, such as renal failure, and also the cardiovascular disease of cardiovascular disease of hypertension. And preferably, they should also have an echocardiogram, especially those patients that have already been known with pre-existing chronic hypertension, and that might predispose them to having this target organ damage. And these patients should be followed up at ANC every 2 weeks. And the key focus is that we need to focus on the blood pressure monitoring and the fetal monitoring, and to assess if they go on to develop the malignant form of the hypertensive disorders in pregnancy, which is preeclampsia. And the elective delivery is advisable at 38 weeks, and preferably beyond 38 weeks, the pregnancy should not continue beyond that. And if they present for the first time in pregnancy, then they should be delivered after 38 weeks. I hope this is clear, and it gives a practical approach in terms of those patients on what to do with these patients. And the key issue is that I mentioned that we should be monitoring the BP. So the question is always, what is our target value in terms of the blood pressure control? Most of us are familiar with the CHIPS trial, and recently the study that was also released that came out last year of the CHEPS trial. And that speaks about the management of blood pressure, especially in terms of patients that have high blood pressure in pregnancy and the chronic hypertension. And what has come out is that we need to adopt what is known as the tight blood pressure control. And the target should be, focus should be on diastolic blood pressure. And this is also being adopted by the ISSHP, that the target for the blood pressure control should be 85 millimeters of mercury, regardless of the systolic blood pressure. It has been found that it is more of the diastolic blood pressure that have an effect in terms of the outcomes and the poor outcome. And I hope this is clear. Again, the CHEPS trial also looked at whether we should be giving medication to patients, especially with chronic hypertension. And the data actually support that these patients should be treated. And the latest recommendation is that we should target the diastolic blood pressure of less than 85. And you can clearly see that based on this, the target should be around 81 and 85. And if you go below 80, these patients are at risk of developing hypotension. And preferably, one of the issues that came out of this study, especially the CHIP study, was the issue of the patients that are having low blood pressure being at risk of having small for gestational age babies. So the key target is about 81 and 80. And we do not want anything more than 85, as it is associated with an increased maternal mortality and morbidity. When it comes to gestational hypertension, once the diagnosis of gestational hypertension is made, the patient should be started on antihypertensive. Again, it follows the same medications similar to those ones of chronic hypertension, and any of these drugs can be used as a first-line medication during pregnancy. Again, a diagnosis, the patient should have a baseline bloods. This is to assess and also rule out preeclampsia. And these bloods routinely should be hemoglobin, platelets, liver function tests such as ALT/AST, urea and creatinine tests. And the baby should be assessed, as you'll see later, that we can also make a diagnosis of preeclampsia purely based on SONA evaluation of the fetus. And they should also have a urine PCR or 24-hour urine DUP, and they should equally be followed up every 2 weeks at ANC, monitoring the blood pressure in the fetus. And the elective delivery is also advisable at 38 weeks. We are now going to focus on the discussion of preeclampsia, which is the most, the chronic hypertension and gestational hypertension. You can refer to them as being benign conditions in terms of hypertensive disorders of pregnancy, and the preeclampsia being the malignant form. So we are going to look at the pathophysiology of preeclampsia. And if we are to look at these two graphs, the picture projects that this is what happens in normal pregnancy. And we know that what we want to achieve with normal pregnancy is that we want to have adequate blood perfusion to the uterus so that it supplies oxygen and nutrients to the developing fetus. And anything less than that is associated with preeclampsia, and that is why this, as we'll see later, that brings up about the disease in preeclampsia. So normally what happens during pregnancy, as we highlighted earlier, that there is cardiovascular changes in pregnancy. One of the cardiovascular changes happens in the uterus. And we know that in the uterus, there is what is known as spiral arteries. These are the arteries that brings blood to the placenta. And in normal pregnancy, what we want as the placenta develops, there is what is known as extravenous trophoblast invasion. And this extravenous trophoblast invasion, as you can see there, they invade into the spiral arteries. And once they invade into the spiral arteries, they cause what is known as spiral artery remodeling. And with this spiral artery remodeling, these small vessels then become what is known as a large bore vessels. And they are enlarged so that they will be able to bring more blood flow to the placenta, so that there is oxygenation and nutrients supplied for the developing fetus. And this is what happens during normal pregnancy without really going into the details. We know that there is what is known as angiogenic factors, such as the vascular endothelial growth factors and the placental growth factors. And these are some of the angiogenic factors that brings about these changes in pregnancy. And as a result, we have what is known as a normal endothelial function. And as a result, we have a healthy baby developing. Contrary to that, in preeclampsia, the opposite is true, that the extravenous trophoblast invasion into the spiral arteries does not happen. And as you can see in this picture, if this process does not happen, there is no spiral artery remodeling. If there is no remodeling, these vessels remain narrowed. And if they remain narrowed, there is less blood perfusion to the developing baby. As a result, we have less oxygen, less nutrients. And as we know very much that that's why the babies with preeclampsia do not grow well, because there is less blood flowing to this baby. And the truth is, with this hypoxia, there is also changes in the placenta, whereby now the placenta releases some toxic substances into the maternal circulation because of this hypoxia, where there's less oxygenation. And subsequently, that is what is going to bring up what is known as this multi-organ disease, as we'll see later in one of the slides. That preeclampsia is not only limited to the uterus, it is a multi-organ disease which is affecting almost nearly any organ in the woman's body, as we'll see later. And this is very true for those patients that have what is known as early onset preeclampsia. And that is why when we speak about aspirin that we give to our patients to prevent preeclampsia, the aim is to focus on working at this area so that we know very much the role of aspirin, that it is given in those patients without any patient with cardiovascular disease, and they do have an effect on the remodeling of the vessels. And that is why we want to give this aspirin before 16 weeks, before the placenta develops. So by the time the placenta starts invading, and if you give it after 16 weeks, that would be too late for aspirin to have any effect on prevention of preeclampsia. Contrary to that, when we speak about late onset preeclampsia, there's this article that was published last year that looked at whether the placenta is a villain or a victim, and the latter appears to be true when it comes to the placenta, because, and this is true for those patients that have a late onset preeclampsia. And why this say that is mainly because we know that those patients that develop preeclampsia, as we highlighted in the last slide, that with early onset preeclampsia, the issue is at a spiral arteries remodeling. And for the late onset preeclampsia, it appears that it has nothing really to do with the spiral artery remodeling, but rather a woman who is already having a dysfunctioning cardiovascular system. And we know that pregnancy can be considered as an early stress test for the cardiovascular disease. So this patient have what is appearing to be a pre-pregnancy cardiovascular dysfunction. And then, as we have already mentioned, that with the stress of the pregnancy, this then brings about then the early pregnancy cardiovascular changes, dysfunction. And this is what brings up about the preeclampsia. And as you can see that these cardiovascular changes tends to even persist even after when a woman is no longer pregnant, or even if they are normotensive. And this is true for those patients with late onset preeclampsia. As I highlighted with one of the slides, that preeclampsia is a systemic, multi-systemic disease that affects virtually every organ in the body. And we have already mentioned that there is an endothelial dysfunction, there is hypoxia, and with that hypoxia brings about pro-inflammation and procoagulation. And this is truly what happens in a woman with preeclampsia. So when we are seeing a woman with preeclampsia, you can imagine that this is a woman who is having this ongoing increased inflammation throughout the whole body, with the increased risk of procoagulation. And we can dissect into the systems. We speak about the big five and the forgotten four. That is why it has been adopted as a good approach, so that you do not miss anything, because each and every organ in the body can be affected by preeclampsia. We have already mentioned the issue of the uteroplacental circulation, why they develop fetal growth restriction, placental abruptio, and even fetal dying. And one of the key issues that related to early onset preeclampsia with the issue of spiral artery remodeling. Kidneys, we know that the patients have endothelial damage. With endothelial damage, most of the time they leak protein, and they also leak fluid into the third space. As a result, there is reduced renal perfusion. They end up with acute kidney injury, and sometimes even with chronic kidney disease or even end-stage disease. Liver, we know that they end up with elevated liver enzymes, with even a risk of liver hematoma. And in a worst case scenario, they can have a hepatic rupture. In the hematological system or hepatopoietic system, there is hemolysis, and this is related to the procoagulation status of preeclampsia. As a result, they will end up with a thrombocytopenia, activated coagulation, HELP, and the DIC, and subsequently at risk of thromboembolism. We know very much about the brain. They will have seizures, and in the other cases, they can have press, or even at risk of having intracranial hemorrhage when there is acute severe hypertension. And they can also have pancreatitis as part of the disease. In the lungs, we know these patients are at risk of developing acute respiratory distress syndrome, with pulmonary edema being one of the complications. Even in the gut, they are at risk of developing intestinal ischemia and necrosis. There is data to show that they are at risk of retinal detachment. Even in the long run, later in life, they are at risk of having this poor sight outcome. On the heart, we know there is an issue about the cardiac dysfunction, especially the diastolic dysfunction, which predisposes them to heart failure, arrhythmias. And this slide just highlights that we should look, when we see a patient with preeclampsia, the focus should not be on blood pressure in the fetus, but to see the patient as a whole from the head to toe, and assess each and every organ in the body to be able to manage these patients. As you can see on this slide, every organ is almost affected by preeclampsia. Again, regarding the diagnosis, and this has been a diagnosis of preeclampsia since 2024 already. Although we know that most of the people are not familiar with this diagnosis, we really need to familiarize ourselves with this diagnosis. And the diagnosis is clear that with preeclampsia, the first criteria that you need to have is high blood pressure. So that's the first criteria. And then if you have high blood pressure and you have any one of the following, first group is, I divided them into 3 groups, as you can see, is the issue of proteinuria. If you have blood pressure with proteinuria, which can in qualitative can be 2+ dipstick or more, that is diagnostic of preeclampsia. If you do not have a qualitative, you can have a quantitative, and the urine PCR of more than 30 milligrams per millimole or 0.03 grams per millimole, or abdomen creatinine ratio of more than 8 milligrams per millimole, or whatever, depending on your local lab test. Any of these quantitative test criteria is acceptable, good enough to make the diagnosis. If a woman does not have a proteinuria of any either qualitative or quantitative, the next thing you need to move on to the maternal organ dysfunction. And that is why we highlighted the issue of doing what is known as preeclampsia bloods, or the bloods that we have mentioned, is mainly to assess if there's any of those maternal organ dysfunction. And we already mentioned on the previous slide that preeclampsia is a multi-systemic disease, and we need to assess the patient from head to toe so that we make the diagnosis. And you can see the part of the diagnosis. Blood pressure alone with the neurological complications, which includes eclampsia, altered mental status, blurriness, stroke, that is good enough to make the diagnosis. If you have a blood with a pulmonary edema, that is preeclampsia. If you have liver dysfunction, which is defined as AST/ALT more than 40 international units per liter, that is preeclampsia. If you have acute kidney injury, more than 90 micromoles per liter, that is preeclampsia. Or if you have hematological complications, especially thrombocytopenia, you can have a patient with isolated thrombocytopenia with blood pressure, and that is also good enough to make the diagnosis of preeclampsia. We know that you can have it also other complications such as HELLP syndrome, but that is also another complication. Then the last group, or the way to make the diagnosis, is looking at the uteroplacental dysfunction. Again, that is why one of the point that we should always assess is the uteroplacental dysfunction. That any patient with elevated blood pressure and with an abruptio placenta, that can be, you can diagnose that patient with preeclampsia and the fetal growth restriction, abnormal umbilical artery Dopplers, and all those patients with elevated blood pressure with an IUFT. You need to classify them into the group of preeclampsia. I hope this is clear. And this diagnosis is adopted already by the ISSHP since 2014. In terms of classifying preeclampsia, we moved away from that terminology of mild, moderate. We only have two, in terms of practicality, two classifications. It's either clinical, those patients with severe features, or preeclampsia without severe features. And these are what are recognized as severe features. As you can see, any patient that is coming with persistently elevated, it's not one reading, but a patient that is having persistently elevated acute severe hypertension of more than 160 or 110 on 2 occasions, more than 4 hours apart. This is despite giving treatment. That is a severe feature. And we know that the difference in terms of severe features and without severe features are associated with poor maternal and perinatal outcome. If there is HELLP syndrome, that is a severe feature. If there is isolated thrombocytopenia alone, that is a severe feature. Any patient with imminent symptoms of imminent eclampsia, I hope we are all familiar with the symptoms of imminent eclampsia. That is a severe feature. Pulmonary edema or acute kidney injury, that is a severe feature. And then any other patient is those patients without severe features. And it doesn't mean if you are having preeclampsia without severe features, you are fine. These patients are still at risk, because as I keep on saying that preeclampsia can be considered as a malignant, meaning that it is a progressive disease until the pregnancy is terminated. Only when the pregnancy is terminated, then we know that the woman is cured from preeclampsia. But as long as she is pregnant, anything is possible. So it doesn't mean if a patient has a preeclampsia without severe features, they are fine. The other way we classify it, we have already mentioned this, and we have also mentioned in terms of etiology, the early onset and the late onset preeclampsia. Although this is more of in terms of, and not really in terms of clinical or making decisions, we mainly use the features in terms of clinical practicality. So the important question that we need to ask ourselves, and I think that is one of the important take-home message, is that why do patients or women with preeclampsia or eclampsia die? So the first one, we know it is mainly intracerebral hemorrhage, and this is also true. One of the slides that I projected earlier is from that confidential inquiries into maternal deaths in Namibia. Stroke was the second leading cause of women dying from hypertensive disorders in pregnancy. The sad part is that this is one of perhaps the sad parts, because most of these patients that die because of the stroke, it is us healthcare workers where we are not really appropriately managing the acute severe hypertension. Again, we need to manage the acute severe hypertension, and we need to manage it proactively to make sure that we lower the blood pressure to prevent this intracerebral hemorrhage. The second reason why the patients die is because of pulmonary edema, and it is also noted in most cases to be iatrogenic, and this is mainly related to inappropriately managed intravenous fluids, whereby these patients end up with flooded lungs and we can't ventilate these patients. Again, one of the slides that we projected as the part of the pathophysiology of preeclampsia is endothelial damage. These patients have an ongoing increased inflammation, and we know that with an inflammation process, there is leakage, vasodilatation, and there's leakage. And if you give too much fluids to these patients with preeclampsia, in most cases, these fluids will end up in the lungs, and subsequently they will end up with pulmonary edema. And then the last reason we know it is eclampsia, and most of the time it's also iatrogenic, where we fail to prevent fits. So patients that need to be loaded with magnesium sulfate, we fail to give them magnesium sulfate, and subsequently they develop fits, and then what follows next is possible maternal death. So in terms of principles of management, we are going now to go into the details of managing, and we are going to spend more time on preeclampsia. We know it's the most serious and malignant form of hypertensive disorders of pregnancy. The principles is that when you are having a patient with a diagnosis of preeclampsia, once you have made, you have diagnosed the patient with preeclampsia, the first step is always to mother first and then fetus. So you first stabilize the mother, then you come to the fetus. You need to do preeclampsia bloods. We have already mentioned the significance of doing the basics bloods, and then mainly this is to assess the multisystemic involvement of the disease. And then you need to treat the raised blood pressure. We have already mentioned that it's one of the leading causes of why women die. And we need to treat and prevent fits. And then the second part is the fourth point is we need to pay attention to the fluid balance. We have already mentioned that because of the endothelial damage, naturally, and also the women lose protein through the kidneys. That's why one of the tests that we do is to assess for the proteinuria. So if you are losing proteins, you reduce your intravascular oncotic pressure, and subsequently by, we know osmosis, that there is diffusion from the obviously less concentrated fluid to the other to balance out. And most of this fluid that leaves the intravascular space goes into the third space. That's why these patients with preeclampsia have edema of generalized or more of anasarca. They have ascites, and that's why they are also prone or predisposed to develop pulmonary edema. As much as these patients are losing these fluids, we need to understand that intravascularly they are dehydrated, meaning that as part of dehydration, they will end up then with there is less blood in the intravascular space to perfuse the rest of the organs in the body, and that's one of the complications is acute kidney injury. Even the eclampsia is related to this pathophysiology of hypoxia in certain parts of the brain. That's why they develop eclampsia. So it is, as much as we know that we are worried about giving these patients too much fluids, we also need to know that their intravasculars are depleted, and we need to support them. And we will speak about later how should we give fluids to these patients. And again, we need to be aware and prevent complications. These are just principles. So in terms of, we've already mentioned, once a diagnosis is made, you need to admit there is no role of outpatient management in a patient with preeclampsia, more especially in the state sector. You need to evaluate the systems. We've already mentioned the importance, head to toe, for all the preeclampsia patients, and we have mentioned and highlighted the significance of doing that. And then depending, and then you assess if the baby is less than 2 kg and you are in an institution where you do not have access to the neonatal unit, perhaps you must refer that baby to the next level of care where that baby can be cared for in the neonatal unit. But if the baby is more than 2 kg and or the gestational age is more than 34 weeks, it is advisable to deliver that patient right away. There is no role for expectant management in a patient who is beyond 34 weeks or a baby that is 2 kg, and we'll show the evidence later as one of the few slides to come next. And these patients should be monitored every 6 hours with CTGs. And we know that when it comes to monitoring low risk, high risk, it is recommended that this patient should be monitored with CTGs. Monitor the fetal growth. And then this is now for the expected management, and preferably even the expected management, this should be done in a tertiary level care under the care of the specialist. There is no role of expected management for preeclampsia in the district hospitals. Management of this is now a patient without severe features, we admit with severe features. So all this group of patients, we're referring now to the patient without severe features. Expected management, preferably as we highlighted, should be done in the tertiary center, and we deliver the fetus when the maternal condition deteriorates, or if there is any fetal compromise, or if we reach 2 kg or 34 weeks, we terminate the pregnancy. Those are the indications. That is preeclampsia without severe features, but preferably in a tertiary setting under the care of a specialist. And then the group of patients with preeclampsia with severe features, this is now the worst class of group of patients. Once there are severe features, the aim is always admit the patient, stabilize the patient, assess if there is a need to do CABs of resuscitation, and these patients, they need magnesium sulfate. Any patients, once you assess them to have severe feature, they need magnesium sulfate because we know they are at risk of developing eclampsia, and we want to prevent FIS. And one of the slides that I showed earlier, eclampsia is the leading cause of why women died in Namibia when we assess the causes of hypertensive disorders in pregnancy. We need to treat the dangerous hypertension, which is the acute severe hypertension of more than 160 or 110, assess all the systems as we highlighted. We do head to toe assessment, monitor the input and the output, evaluate the fetus once the mother is stable. So what we see in most clinical practice, especially in clinical practice, not to just to highlight that most of the time a patient presents to admissions. Once we're busy doing the vitals, the next thing the CTG is up running. That is not the approach, because if you have a CTG, then you'll be now starting to think, should we go to theater right away? Patient has acute severe hypertension. We have had patients know that if you go take a patient to theater with uncontrolled acute severe hypertension, they are predisposed to be at risk of having intracerebral hemorrhage, as we highlight. So the aim is always attention should be paid to the mother first, and then the fetus. There will never be a healthy baby if you do not have a healthy mother. And then the aim is that once you have severe features, the aim is to deliver, if you are in a place where there is access to the resources to deliver this patient, especially if it's preterm, early onset preeclampsia, or to refer to the next level of care if you need to refer where there is, especially the neonatal services. So how do we manage the patient with acute severe hypertension? We have already mentioned that these patients are at risk of having a cerebrovascular accident. The approach is that if they are conscious, you can give them oral treatment, which is nifedipine, 10 milligrams per ostet, and you must be sitting there with the patient. This is not the patient that you prescribe and you go and come back after 4 hours. You need to sit there and repeat the blood pressure after 15 minutes. If the blood pressure is still elevated you give another dose of 10 milligrams per stat, and then you need to be sitting there until you control the blood pressure. You only leave that patient for another next patient once the blood pressure is controlled. And you need to be aware of the contraindications to using short-acting nifedipine, such as tachycardia, cardiac lesions, or those patients that are unable to swallow. And the other option that we have available is the IV dose of labetalol that can be given in these doses. Starting off in the first, you give a loading of 20 milligrams IVI state, and then you need to be sitting there every 10 to 15 minutes. You must review the blood pressure. And the aim is that you want to lower this blood pressure to be less than 160 over 110. And you must be there lowering this blood pressure yourself. These are not cases that you leave and you come back later. And this is a practical approach on how we should be using. The other drugs that are also available includes hydralazine, as you can see there in this slide in the middle. This is labetalol. You can see at 0 minutes you can give 20, and then you review the blood pressure. And then if the blood pressure is still elevated, you can double that dose. And again, after 10 minutes, if it's still elevated, you can double the 40 milligrams to 80. And you can see this should be done in sequence. You should be there and be giving these medications. Equally, so you can see with hydralazine, the approach is the same. And also with nifedipine, it's a time factor. You should be lowering this blood pressure. As you can see, we have a time on the left axis there. So this is what I was referring to, whether there is a role for expectant management for patients with preeclampsia with severe features. We already know this study, which is known as the MEXPRE-Latin trial. It has showed us and told us that there is no role for management of expected management for those patients between 28 and 34 weeks. So if a woman comes and she has preeclampsia with severe features, it appears that the benefits of delivering outweigh the risk of expected management. And there appears to be the risk of abruptio, small for gestational age, and also the risk associated with especially cerebrovascular accidents. And interestingly, one of my colleagues, when I was at school, also did a study similar to this in our setting at Kalafong Hospital. And the findings were pretty much similar to the MEXPRE trial. So the latest evidence, patients with preeclampsia with severe features, you stabilize the patients, you give the steroids when they are less than 34 weeks. And obviously, even with steroids, you need to individualize. These are not patients such as those patients with HELLP syndrome. You do not have to wait to give for steroids maturity. You can give them one dose and immediately you terminate the pregnancy. Because we know this is a malignant disease and it's progressive. Every second ticks, the disease is a progressive disease. Again, why do we deliver patients at 34 weeks? There's this data we know, it's known as the Phoenix trial. It looks at whether we should be managing the patients with preeclampsia beyond 34 weeks. And actually this study actually supports that patients there is no role for expected management beyond 34 weeks pregnant. And it was found to be the benefits of delivering outweigh the risk of expected management. We know very much that some of the guidelines, especially the NICE guidelines, and perhaps the Americans would say preeclampsia, wait up to 37, 38. And if we are to look at the available evidence, it appears that there is no role, and we know that very much that the disease of the burden is this part of the world, especially in sub-Saharan Africa. And that is why most of our recommendations on this part of the world is that 34 weeks, we deliver, and there's data to show that it is beneficial. Again, there is a follow-up study that was published in May of last year, and it was a 2 years follow-up of the infants and the maternal outcomes after the planned early delivery or the expectant, or they followed up whether when we are delivering these babies at 34 weeks, whether we were doing any harm to these babies. And the evidence appears to show that there was no any differences in terms of neurodevelopmental assessment when these babies are reviewed at 2 years compared to those babies that were delivered at term. But if you look at the possible morbidities and mortalities, appears to be more for those patients that were expected. So again, this data is actually a very, very critical data that supports our current practice of delivering patients at 34 weeks. So who should receive magnesium sulfate? We mentioned this earlier, that patients with acute severe hypertension, patients with preeclampsia with severe features, and those obviously patients with eclampsia, all these patients should get magnesium sulfate. We know that it is the anticoagulant of choice, and there's many different regimens, such as the pre-charge regimen or the Zospen regimen, and we need to be familiar with all these regimen. And the pre-charge regimen is more applicable, especially when a patient is being referred from a rural place where they might not be monitoring, or the patient cannot be monitored in transit. Rather to use the pre-charge regimen, which is the IM-based regimen, compared to the Zospen regimen, which is an infusion-based regimen that requires close monitoring to prevent magnesium side effects, especially magnesium toxicity. So this drug also has its own side effects, so we need to be very much aware of that. And that is why when we are giving this medication, we need to see why we are practicing within our, so that we do not end up with bad outcomes. Regarding fluid management, all patients with preeclampsia should be catheterized, especially preeclampsia with severe features. You should monitor input and output chart. Preferably, if you have a high care, these are patients that should be put in high care setting. We mentioned the issue of intravascular depleted. It is advisable that we give these patients fluids to replenish their intravascular fluid, but it should be limited to at least 80 mL per hour, not more than that. And we know that most studies have shown that the more you give, the more they are at risk of increasing pulmonary edema. And we need to monitor the urine output, and preferably we want them to have a good urine output. And if they have a decreased urine output of less than 30 mL per hour, you can give only one single bolus of up to 300 mL. These are not patients that we use such as in those bleeding where there was septic shock, where you use 30 mL per kg. Our bolus here in these patients are limited to 300 mL of ring acid bolus, and you only give it once. And the worry is always pulmonary edema in these patients. So the key message is that it is better to run these patients dry than to drown them, because it's very difficult to treat patients with pulmonary edema. There is a point of no return. If they come to a point where you can't ventilate them, most of the time they end up with a maternal death. And we know very much that these capillaries are leaky, as we highlighted earlier. There's also a risk of getting cerebral and also, as we highlighted, pulmonary edema. So it is very, very important that this, preferably also because of the capillary leakage in the intravascular dehydrated, preferably this patient should not be given diuretics. We know one of the medications that is always used, especially in those patients with hypertension, is diuretics. So the only role of diuretics in managing patients with preeclampsia is limited to those patients that have pulmonary edema, but not to control the symptoms in any other way. So evaluation, we use the basic principles, and it's please very important that we stick to this basic principle that we have been taught of Big Five, forgotten four, and it's a very good system so that we do not forget any system. Yes, preeclampsia is a multi-systemic disease from head to toe, that is CNS, respiratory, cardiovascular. You assess the liver. And the key here, especially the liver, and we routinely ask the patients if they have epigastric pain. When we are asking about epigastric pain, it's issues related to the liver, because if a woman has an epigastric pain, then you must know that that woman is probably having a subcapsular hematoma, or even a liver rupture. We recently lost a woman because of this condition with preeclampsia, I think about 2 weeks ago at our hospital. So it is very, very important to assess for these patients. Renally, again, the forgotten four systems, hematologically, you can see that some of these hematological requires lab. So that's why in patients with preeclampsia, the laboratory assessment is critical. These are not patients that you do bloods today and you trace them tomorrow. You'll be shocked that the patient is, you'll be sitting or having a patient in the ward with platelets of 10. So these are patients that you immediately do bloods, and you preferably even wait for the bloods at the lab and come back with the results. And we need to improve on, especially on this aspect of laboratory and getting the results, because it enables us to make critical decisions. and even the liver system, all this requires, some of these systems requires integration of the clinical with the laboratory when we do this full assessment of the big five and the forgotten four. And that is why you can, the assessment of a patient with the preeclampsia is incomplete in the absence of laboratory-based investigations. They form part of the critical core of assessing these patients, and it should be done as soon as possible when we see these patients. Again, then we assess the core one that we speak about is the obstetric examination, where we focus now on the fetus, and then core two, we speak about the vaginal assessment. If we can all adopt and follow this simple systemic approach, the way we have systemic approach of interpreting CTGs, perhaps this will really go a long way to help us reduce maternal deaths related to hypertensive disorders in pregnancy, especially preeclampsia. And the emphasis is, again, is on laboratory investigations. I've seen it also at my hospital here, that most of the things that is not being done when we have these patients, blood results are not traced on time. So maternal stabilization, again, this is just points to the issue that I highlighted previously, that we need to have lab results to allow us to fully assess the patient. And it is not appropriate to monitor the fetus before you have the blood results, because it's the blood results will give you the whole picture of the patient. Because as we highlighted, preeclampsia is a systemic disease. You need this, and then once you then have these blood results, it allows you to give a full picture. You'll be surprised that you'll be dealing with a patient with HELLP syndrome, acute kidney injury, or anything else. So that's why it is very, very important to trace the blood results as soon as possible. We know that in most cases, a full blood count, especially it takes about 15 minutes. So we should get those blood results as soon as possible. In terms of evaluation of the fetus, we need to evaluate the fetal viability. We know that if those ones that are less than 34 weeks and less than 2,000 grams, they should be given steroids. And then you should arrange transfer or deliver if you are in a place where they have neonatal facilities. And for those ones that are pre-viable, those ones can be considered for termination of pregnancy. And again, I just want to highlight this point, that there is no role for managing these patients expectantly in the district hospital, more especially when you cannot get blood results on time in some places. In terms of delivery, we have already mentioned that preeclampsia is a progressive disease, and the only cure is to terminate the pregnancy. Again, those ones that are pre-viable, should be cancelled and considered for possible termination. And for those patients, preferably vaginal delivery should be the best choice of mode of delivery. And it is often necessary to individualize the patient. So any other indication, there's nothing such as we are going to do a cesarean section for preeclampsia. So we individualize and we then manage the patient. Eclampsia, this is just a slide that we know an approach is that it's an emergency, and which all of us should be able to manage and handle patients with preeclampsia. We use the basics: airways, oxygen, IV access, avoid maternal injury, and we load the patient with magnesium sulfate. You can see the dose that is highlighted here. This is a dose that we do not really use in this part of the world, but it's another regimen, CBI regimen, that is used in other places. But we use either the pre-shot or the suspend most of the time. And again, you can see part of the critical there, and I want to highlight this, is within 20 minutes, you must get the blood work. You need, with all these type of patients, laboratory-based investigations are critical, and they are key to managing these patients. You can never manage these patients without getting the blood work. Again, with this, there's no role for expected management. We know once a woman has eclampsia, it requires an immediate delivery. Magnesium sulfate monitoring, I highlighted this when I was mentioning the issue of Zospen and the pre-shot regimen. We know that you need to assess for the possible signs of toxicity, such as absent knee jerk, urine output less than 100 in 4 hours, or respiratory rate less than 16 breaths. And the antidote of choice in terms of magnesium sulfate toxicity, we should know about this, is calcium gluconate 1 gram. That should be given over 10 minutes. In terms of immediate postpartum treatment, this patient should never be discharged within 24 hours, because it is evidence have showed us that this BP peaks around 3 to 6 days after delivery. So we need to keep and monitor this patient. And those patients that are on magnesium sulfate, they should continue with it up until 24 hours after delivery or 24 hours after the last feed. And we need to keep the women with the eclampsia and those with organ dysfunction not less than 3 days before they are discharged. And if we are to reduce the antihypertension, it should be done in a stepwise, shouldn't be done abruptly. And the antihypertensive of choice in the postpartum period, again, it is now safer this time to use the ACE inhibitors. Any of these, including the calcium channel blockers, can be used, except the alpha methyl dopa. ACT is associated with the incidences of postnatal depression in the postnatal period. So immediately after delivery, you need to stop those patients that were on alpha methyl dopa and start them on either ACE inhibitors or the calcium channel blockers. And in the last case scenario, if they are not really responding to the ACE inhibitors or calcium, you can add diuretics. And then it is also important to note that we mentioned that the issue of intravascular depletion, it's also predisposed this patient to be at risk of venous thromboembolism. Not only that they're intravascular depleted, we also know, if we are to recap on the VCOS triad, there is also endothelial damage. Patients really require prophylactic clexane because, anticoagulation, whatever you have, and we should mostly use clexane because they are at risk of forming clots. And we need to ensure appropriate contraception, and we need to counsel these patients about the future pregnancies and the long-term outcomes, the risk of developing eclampsia in subsequent pregnancy or other cardiovascular complications such as chronic hypertension, renal disease, stroke, dementia, acute myocardial infarction. And advisably, these patients should be reviewed at 3 months, 6 months, and 12 months post-delivery. As we have seen that actually there's more evidence that is coming out to show that we are also seeing more hypertensive patients with hypertensive disorders of pregnancy dying in the postpartum period. Most of the time we deliver them and we think everything is done, but we tend to lose more patients even in this postpartum. So we need to critically have a good follow-up plan for these patients. In terms of prevention of preeclampsia, we must be screening for preeclampsia, and we use the Fetal Medicine Foundation triple test, which has also been adopted by FIGO. And it is the universal screening, which requires a combined test, and it has a high detection rate of about 90% for early onset preeclampsia. And for the first trimester, we look at this triple test is based on the maternal risk factors, on the mean arterial blood pressure, and the biomarkers. Any woman that has these risk factors, such as a previous history of preeclampsia, chronic hypertension, multiple gestation, pre-gestational diabetes, maternal increased BMI or obesity, patients with autoimmune disease, or those patients that have assisted reproductive technique pregnancies, they all qualify already without even going into further testing to be started on aspirin. So this patient should be started on aspirin 150 milligrams per os nocte. The other assessment tool is that you need to assess the mean arterial blood pressure, which is expressed in multiples of median. So there is a formula that we use that is available that can be used to assess the mean arterial blood pressure, although this is not widely accessible. The other that can also be used is the uterine artery pulsatility index. And with the uterine pulsatility index, with skills, it's actually easy to do this. You'll be able to predict those patients that are at risk of developing preeclampsia. And this is now independent of these risk factors. So this is a young patient that comes in. If you do some of these patients random screening, and in my experience, I've picked up a few, and actually some even went on to develop preeclampsia even after giving them aspirin. So if we are to look, and then the last one is the biomarkers, which refers to placental growth factors, PAP-A, which are not really widely accessible. So based on this screening, if we are to look at what we have perhaps available to us, is definitely, this is history-based screening. We can do this and identify the patients that will benefit. Even with this better training, those patients that will be able to assess for the uterine artery pulsatility index, and you just look for the what is known as the post-systolic notching on the uterine artery, and then automatically these patients are at risk of developing preeclampsia. If you put them preeclampsia, you reduce their risk by about 60%, as you will see later on one of the slides. The other ones are not widely accessible, but at least this we should be doing to reduce these deaths. And this is what the Europeans and the Americans have been doing. If you recall one of the slides that I showed on the Embrace report, that is why they have a very low preeclampsia incidences in that part of the world. Again, the drug that we use what is known as universal for all women. It is advisable for those patients that have an intake of less than 900 milligrams, but we do not have a very good way of measuring who is taking less than or more than 900 milligrams of calcium. So it is also advisable by WHO to put all the patients on calcium 1 gram per day as part of reducing preeclampsia. And then for those patients that are high risk, this is then we put them on both combination of calcium and aspirin. And as I highlighted, that this data is from the aspirin trial, and the benefit it reduces preeclampsia by about 62%. And again, it should be started before 16 weeks. And at 36 weeks, it is important to remember to stop aspirin. There is no role of starting aspirin in a patient who is at 37 weeks. It's only before 16, and it should be stopped at 36. We know that aspirin in itself irreversibly inhibits the platelets for as long as the platelets are alive, and we know that the platelets live for about 90 days. So the aim is that by the time the patient is going to labor, perhaps they have new plates that will prevent and reduce postpartum hemorrhage. In terms of long-term risks, this long-term risk can be divided into maternal and fetal. In terms of maternal, we know that preeclampsia, there's data to show that, and one of the people that have done a lot of work on this issue is Professor Mapile at University of Pretoria. She did a lot of work on this preeclampsia as a risk factor for cardiovascular diseases, and it predisposes these patients to chronic hypertension, stroke, intravascular hypertensive disorders, and also vascular dementia, renal disease. For example, those patients that has preeclampsia, they have about a 4-fold increase to develop chronic hypertension in 2 years. Diabetes is about a 2-fold increase. So it is very important that when we see these patients, we need to do a lifestyle modification so that we can help them prevent these adverse cardiovascular disease outcomes. In terms of the fetal, it has also been found that hypertensive disorders have about a 1.4 and a 1.3-fold increased risk for autism spectrum disorders and ADH. So again, it just shows the effects of this condition. It's not only about, and one of the studies, the Helsinki birth cohort study, also found that there's an increased risk of these babies that are born to the patients that have hypertensive disorders of pregnancy to be at risk of type 2 diabetes and obesity. I added this slide just to mention, I know there's midwives also on this platform, and I really want to highlight this, that they also importantly form part of the management of these patients with preeclampsia. Why they are key, they might be the ones in high care. So it is very important for our midwives to recognize and act on acute severe hypertension. So there's no point of doing a blood pressure that is acutely severe hypertension and you are not calling the doctor, you are not giving the medication. So please, this is a team effort and we really need to work together and to lower this condition. Also equally so, if you are monitoring a patient in high care, it is your duty to make sure that you recognize the signs and the symptoms of pulmonary edema. We have already highlighted, such as shortness of breath. So you'll be monitoring a patient is complaining of shortness of breath, but there is no action, especially if you have a preeclampsia. When they start complaining of shortness of breath, orthopnea, or they are desaturating, you need to have a high index of suspicion for possible pulmonary edema. And it is very important that we highlight the doctor on time so that we'll be able to manage this patient. It is also important to note that one of the classification that is coming out is the issue of postpartum hypertension or postpartum preeclampsia. The etiology is not certain. We know that traditionally preeclampsia has always been mentioned that it is a pregnancy disease, and once the pregnancy has ended, there is no preeclampsia, but there is now more evidence is emerging that there is a phenomenon of postpartum preeclampsia, and the etiology is related to the immune system that has to do with the T lymphocytes and the natural killer cells, although it is really not fully understood. And it is noted to affect about 8% of women that even do not have any antepartum hypertension. And it has been documented in up to 48 to 6 weeks. That is why it is very important that we need to follow up our patients after they have delivered. And it is also documented that in those patients that have preeclampsia, they can develop actually postpartum eclampsia and preeclampsia in 50% of these patients. And why this talk is significant, as I highlighted earlier, that about 60% of maternal deaths actually occur in the postpartum period. Although we know that the postpartum period is only up to 42 days, there is now data to show that most patients, even after those 42 days and to up to a year, most women end up dying, and it is noted to be as high as 60%. And one of the causes that when they reviewed those patients, it was found that hypertensive was one of those leading causes among those patients that died immediately after having a baby within a year. And then importantly, also postpartum hypertension also offers us an opportunity to use those medications and to achieve very good BP goals without this issue of worrying about the antepartum, such as medications that have impacts on the fetus. So I'm coming close to the end of my talk. So if we are to recap, we have mentioned the issue of recognizing eclampsia and preeclampsia with severe fissures, resuscitation and drug management, the use of magnesium sulfate, monitoring of patients on MEG-SALF, fluid management, complications of preeclampsia, delivering those patients with eclampsia and preeclampsia, and prevention of preeclampsia. So to conclude, I would like to mention that the top 5 causes of maternal and perinatal deaths remain unchanged. Either obstetric hemorrhage or hypertensive is usually the two. Hypertensive disorder is still a problem and it's on the rise. And the focus should be on managing patients with acute severe hypertension, to avoid patients being flooded with fluids, to give aspirin to these patients with high risk. These are the key take-home messages. And I just came across this World Congress that is planned to later this year in September. Perhaps we should be looking forward to the maybe sometime next year to the latest recommendation regarding the management of the hypertensive disorders in pregnancy. And perhaps this will probably also maybe bring changes that I highlighted earlier regarding the diagnostic threshold. Don't be surprised if you find that it is lowered to 130/80. And I'm looking forward to the outcome of that Congress. And these are the references that I've used. And I would like to thank you, colleagues, for being with me. It's quite a very adverse and a big topic, but I tried to squeeze in. The floor is open for some questions or any point that I might have omitted. Thank you very much, colleagues.
Dr. Mvula. That was very, very, very powerful. Dr. Bagagula, are you there?
Yes, I am, Dr. Mawela. I'm just going to switch off the video. I think I'm battling it a little bit here with my connection. But I think, yeah, that was a lovely presentation, David. Quite extensive, well-researched. And as I said, you're an evidence man. And I think you've really done justice. We apologize again sincerely for giving you such a broad topic, but I think you killed it. So thank you so much. With regards to the questions, I've sort of grouped them, and Dr. Mawela will assist, in case I've missed some of them. But I've grouped them to diagnosis.
Yes, before you go, if we can just take 2 questions, and then I want to challenge you and Dr. Mvula that we must come back this week and bring back people who are attending here and do justice to the discussions. So it will be just a Q&A session, and we go through, because there's many questions which are very, very important that I feel we need to go through. So if we can just take 2 questions, and then we do closing remarks, and then we assess whether Wednesday or Thursday, we just come in and everyone joins in and we go through some reflections, and then we go through the questions. I think that would be a great way to deal with. But I think let's go through at least 1 or 2 questions. Thanks. Yeah.
No, perfect. Thanks, Alex. I actually think that's a better plan because there's so many questions, and I think we can never really do justice to just 5 minutes of Q&A on hypertension. So just two questions, Dave, please. One is on prevention, basically around the use of aspirin. There was one question from probably a midwife colleague who's asking whether a nurse can initiate aspirin at a local clinic level, so level 1 or primary health care. The second one being initiation of aspirin after 16 weeks. Then I'm going to ask the other sort of group of questions around Mexalf. If you can please respond to the one on aspirin, who can initiate and can we initiate after 16 weeks?
All right, thank you very much, Billy. I think these are very key questions. In my view, the midwife at clinical level initiates antihypertensives or even most of the medications for that matter. And for me, aspirin is a drug that is available over the counter. So I don't think there is any reason why they shouldn't initiate, and perhaps we should really encourage them. That the key is still that slide that I highlighted, the history-based. If we can identify those patients, in my view, anyone should be able to initiate these patients on aspirin. And the issue of timing, even if you go to the aspirin trial, even with among those patients that are started between, even the aspirin goes on to speak about 16 weeks and 28. There is still some significant reduction, although it is not really significant. It's about half of what is achieved if you start with you start aspirin before 16 weeks. And again, that is why I try to highlight the issue of spiral artery remodeling, because the key on how we think aspirin works on improving or preventing preeclampsia is related to the vascular remodeling. And again, we know most of the patients that have cardiovascular diseases, non-pregnant, when we refer to any patients that they are taking aspirin. If you had a stroke previously, those patients are started, and it's based on that theoretical background that aspirin has some effects on the vascular remodeling effects. I hope I have answered you, Billy.
No, definitely you have, Dave. Just maybe 2 more minutes, please, Dr. Mawela. There's some questions around the use of Mexalf, and I think policies are different, between hospitals. What most of us probably have been taught is that if there's any signs of severity, whether it's BP or whatever, you actually give Mexalf. So there was a question at 1905, but also a similar type of question asked by Dr. Rugega, who's out in Botswana, at 1907, around the use of Mexalf, to say if the patient only has an elevated BP and nothing else, acute severe hypertension, but nothing else, or if the patient has got, severe features, maybe with thrombocytopenia or fetal affectation. Yeah, actually, no, sorry. The second one was around delivery, timing of delivery. But as to the use of Mexalf, in a case where there's only one severe feature, should we give Mexalf or should we have more than one severe feature? Before I ask the last question from the doctor.
Okay, quickly on the issue of, especially if you only have BP, if you go back to you remember that slide that I highlighted on the issue of severe features. Acute severe hypertension alone, by definition, if you have a blood pressure of 160 and you manage to control it within 4 hours, that is not a severe feature. But once you have persistent acute severe hypertension, by definition, if it's going on, even despite you giving those short-acting drugs and starting the patient on the long-acting, and the BP is still not controlled, then those are the patients that is when you classify these patients to be severe feature. But if they are just having a single reading and then you start them on antihypertensive and the BP is coming down normally, and then when you go and screen the systemic organ involvement and there is nothing, and then you can classify them as preeclampsia without severe features that presented with acute severe hypertension. Maybe you can add, Billy. I think that's my...
Yeah. No, I think you've answered it well, Dave. And yeah, from one hospital to another, I mean, some would actually start, some don't start. And I think, yeah, as we said, it's all guidelines and you want to individualize your management. Same as the issue of the use of fluids and all. Now, one last question, perhaps before we wrap up. I think this is associated, it's actually based on the Max Pre-Latin trial that you had presented, whether or not, we should deliver those with preeclampsia with severe features after 48 hours of giving steroids. It's actually a question from Dr. Rugega out in Botswana again. So patients with severe preeclampsia or preeclampsia with severe features after 28 weeks, should we just deliver after 48 hours or wait, until 34 weeks? Your comment on that, please.
Yes, do. Okay, so the approach is that, again, I think, Billy, you mentioned about individualizing. We individualize the patient. So if a patient is having severe features that, for example, that require immediate delivery, it's again individualizing. We know that, for example, patients with HELP syndrome, you wouldn't want to wait for steroid maturity before you take out the baby. But if it's only the BP and the BP is being controlled and you still assess them to be those patients with severe features, the guidelines is that, yes, you can give 48 hours of steroid maturity and then you deliver the baby. But so it's all about individualizing, more especially we have highlighted that the issue is that more especially those patients that have HELP syndrome, they tend to worsen and worsen, and you don't want these patients to deliver when they are having platelets of 9 and that. And I think that's also what I think one of the studies of Nsako showed, that you individualize, and then some of the patients you can wait to give steroids, the others, based on the clinical scenario, you terminate right away, even after giving 1 dose of steroids. Billy, you can add.
No, I fully agree, Dave. I know that, if you look at the levels of care and what each hospital can offer, I mean, if you look at perhaps where we are, even at the highest level here in our province, we might have limitations, with regards to caring for those very small babies. So if you individualize them well, you might actually be able to keep some of them intrauterine, perhaps with some benefit. But we know many of the studies actually have shown that there's really no benefit with waiting. In fact, you run the risk of many complications. I think probably there's one study as well from Prof. Pattinson quite many years before the Max Pre-Latin, with similar findings before the Max Pre-Latin trial. So there's definitely evidence, to say waiting doesn't really give you much, but then you look at your local circumstances to say, if you deliver, are you likely going to look after this 28-week? How about you push maybe for a couple of weeks and, hope for a benefit of some sort? So yeah, I fully agree. The evidence says deliver, but yeah, it depends, I suppose, on where you are and what resources you have for these little ones when they come out.
Most definitely.